Good morning, everyone. I hope all of you are enjoying the historic New Orleans. I'm Dr. Siddique. I'm from North Carolina. And before I get into my actual presentation, I want to share you this. But when I was a kid, got to spend a lot of time with my grandmother. Of course, grandmas are little old ladies. And so they are supposed to have different kind of ailments. But when I started going to med school, she always complained about a lot of back pain. Of course, she thought that I knew everything. In fact, I knew nothing. But then she was losing her height with that. So now that I think about it, she had osteoporotic bone fractures. And with that, I begin my talk for you all this morning. So we change on our outside as we get older. And similarly, this is me in next 15 to 20 years, similarly, our bones would also change. The bones, nice and plump, hopefully I have them on the left side, and they're going to change on us. This is a natural process, and they get porous over time. Our posture changes. We are nice and erect when we are in our younger age group. We get older and we slouch. This is, again, a natural process. So I will go over a few that I have put at my objective. So the definition of osteoporosis, the newest one is that it is a skeletal disorder characterized by compromised bone strength, predisposing to increased risk of fracture. Also in that, you are going to include low trauma or fragility fracture, that is fall from a standing height or less, and that is also called osteoporosis. So there is a certain time in our life when we are going to obtain our peak bone mass, and that's typically in our late teens or early 20s. After that, we do not get any more bone mass. And so most of it is our heredity, up to 80%, and then rest of it where we can make a difference possibly is our lifestyle factors. And among the lifestyle factors where we should pay more attention to is the nutrition, like the protein, calcium, and vitamin D. Endocrine factors play a role, like your sex steroid, calcitrol, GH, IGF axis. Smoking and alcohol, they will adversely affect our bone densities. Mechanical factors, the amount of physical activities we are putting in there, our body weight, like low body weight is always associated with low bone mass. Gender. This is just a pictorial view of what I just said. But then again, we start losing our bone. We lose our bone at the rate of 0.5 to 1%. And this starts pretty early, age 40. And then as women hit their menopause, it goes down pretty sharp. And that will continue for next 5 to 10 years. Then the age-related loss will continue on, and it will go back to your pre-adolescent level eventually. So their bone density is higher in men than in women, and in blacks is always higher than in white, and age is always an independent risk factor. These are the systemic factors. I don't dare to go over this slide here. Now, the prevalence is not little, about 200 million with, this is all over the world, 10 million, and of them, of course, again, women are the main victims, and about 8 million, and 2 million are male. And in US, the fracture every year is 1.5 million. This slide is a little old, so I would think that it is a little higher at this time. So the cost is pretty high. Each hip fracture is costing $40,000, and 17 billion is spent in US, and then the comorbidity of the major ones, including your MI, stroke, and breast cancer, in female, that will not exceed the osteoporotic fractures. Those pretty high. And so what happens when you break a bone? And pain is a huge deal, vertebral fracture mostly. Loss of height You get your deformity and your decreased vital capacity as a result of this. Depression develops, and the mortality also increases with it. Hip fracture, 24 to 30% have increased mortality within the first year from the complications of hip fracture. And that leads to a permanent incapacity. Long-term care, a lot of them, they have to be put in there. The bone density, what could affect it? Among multiple, advanced age, low body weight, as I mentioned before, usually BMI less than 19 more, late menarche, time since the menopause, smoking, alcohol, and how much calcium we're having in our diet. The low bone density test, and then when you come to the fracture, the bone density, if it is low, it will increase your fracture risk, age, prior history of fracture, your family history of the fracture itself, chronic smoking, low body weight, fall, and loss of muscle mass. And here, see, there are a lot of secondary causes where we as physicians probably can make some difference by paying attention. But in 47% for osteoporosis, we don't have any cause. Number of other conditions, these are the ones that I have listed as the secondary causes. They're a good list of the endocrinopathies, mostly pay attention to hyper and hypoparathyroidism, which is pretty commonly we see. Among the drugs, there are quite a few that are used more often. Look at PPI, thiazolidinedione, Depo-Provera, heparin, thyroid with the suppressive doses. Steroid, whenever it's used for a long time, they will affect our bone density adversely. Many more causes from GI and inflammatory that I have just put that in there. I'm not going over all of them, but they do include the marrow and neoplastic processes, genetic conditions. They all would affect our bone density adversely. Included anorexia nervosa, liver disease, renal disease, COPD, AIDS, different kind of malignancies, and vitamin D deficiency. Here again the dietary lack, and we don't get to spend a lot of time out in the sun, and GI, liver, renal disease, and drugs like phenytoin and phenobarbital. This is one of the examples of the secondary. This lady had renal transplant. She is on long-term chronic steroid. She came and tells me that, doctor, I have lost 6 inches of my height. I really didn't believe her first, but then on the x-ray, she sure enough has all over cervical, thoracic, lumbar vertebral fracture. Think about her, what a misery. The life is poorly now lived. Now, how we make the diagnosis? Still, the gold standard is using the DEXA scan. And DEXA scan is, there are many different places where the DEXA scan is done. At our office that we have as primary care, we use the GE Lunar. And the main thing is that when we're using the DEXA scan, and then for the serial measurement, we should try to use the same machine, because usually the BMD is not, they are not that closely comparable with different machines. So who can get DEXA? Like everything else, is Medicare, and the insurance will guide us on that. But if you can code well, you can get this covered pretty good. Estrogen deficient women who are at clinical risk, vertebral abnormality, if you happen to get an x-ray and there is vertebral abnormality, you can ask for a DEXA. Steroid therapy, these should be really closely monitored. Patient with primary hyperparathyroidism, and when you monitor a drug test, Medicare usually pays for this. National Osteoporosis Foundation, they will recommend DEXA for women over the age of 60 and for men over the age of 70. Younger postmenopausal women and men between the age of 50 to 70, if they have a risk factor. And perimenopausal women, again with risk factors, conditions associated with high fracture risk, like the secondary ones that I mentioned, and adults after a fracture, age 50, then you can consider that too. Now we look at a score called T-score. We are going to interpret the result of your DIXA scan, and the T-score, WHO, according to them, it is normal if this is -1 or higher. It's called osteopenia or low bone mass when this is -1 to 2.5, but then it's osteoporosis when it is -2.5 or less than that. I think the lowest I've seen is -6. The severe osteoporosis is when you have -2.5 or below, but there is a fragility fracture, and then that is like when this is a fall from a standing height and you still break your bone, that's the fragility fracture. So who gets treatment? We have pretty clear-cut guideline now on that. So someone who has a history of vertebral or hip fracture, they are high risk. So you do put them on a treatment. T-score, by that, we go by -2.5 or below. And then there is another one that we go by now is the FRAX score. And FRAX score overall is if it is 3% and for your hip and other places 20%, then there is a strong indication of treatment. So for FRAX score, it has actually made it pretty even all over for us to understand who to treat. And so in that, there are certain parameters we will feed the computer, and it will give us the your ratios to figure out who should be treated. So we pretty much go and put in their age, sex, prior fracture, parental history, their use of tobacco, alcohol, history of steroid use, and certain conditions like rheumatoid arthritis. Treatment, non-pharmacologic, is where we will start first. Adequate, that's the key word, adequate, 1200 milligram of calcium in divided dose, and then vitamin D, we need about 800 to 1,000 IU daily. Regular weight-bearing exercise is not just the aerobic. Aerobic will increase our hip, but for other places, we need to work on other weight-bearing exercises. Avoid smoking, alcohol, and try to prevent fall to stop breaking that bone. There are a number of medication available now, estrogen, and then that was used before more often, but because of the potential side effect, much less now. Alendronate, risendronate, and ibandronate, these are the oral bisphosphonate. Zoledronic acid, this IV bisphosphonate. Salmon calcitonin is not used anymore pretty much because of low efficacy. Evista or raloxifene, which is a SARM, that is also used. Denosumab, that is used, is one of the newer ones, very good drug. And the anabolics are the teriparatide, and the most recent one is the abaloparatide. And these are efficacious drugs, and that we are using now for severe osteoporosis. And so risk reduction, if you look again across the board, they do help in both areas of your hip and the vertebral fracture for most of them. And but if you look at this for the spine, all of them, they have a positive effect on that. So combination therapy, there are certain ones on the combination therapy, but this is not really something that is used. This was just a theoretical, I would think. The complications, estrogen replacement, you all know, venous thrombosis, cardiovascular, breast cancer, endometrial cancer, dementia, so it has fallen out of favor. Bisphosphonate of all, we see about the GI intolerance. I think I see this the most, that they have this GERD symptom getting worse on them. And so musculoskeletal pain, not as much the day after maybe, flu-like symptom, but then ONJ, this is over-exaggerated than what the actual prevalence is. So every patient, they will say they have trouble with it, but it is actually between 1 in 10,000 to 1 in 100,000. Atypical femoral fracture, this is something we need to watch for. If someone on bisphosphonate therapy and complaining to you about a hip fracture, let's go ahead and get a hip x-ray just to make sure if they have it. Hypocalcemia, adrenal dysfunction, yes, it can do that. Atrial fibrillation, esophageal cancer. Teriparatide is the one that has in animals